So again, my conflicts. So tonight we'll discuss bulking agents. We'll discuss the anatomy of the urethra technique. We'll discuss the various agents, and then we'll discuss the future, which is stem cell possibilities, which are very exciting to me. So our whole goal in bulking of the urethra is to recapitulate, to recreate the, if you will, the seal mechanism of the urethra. So this is the cross section of the urethra, mucosa, lamina propria, muscularis. And the lamina propria, where the seal mechanism is created by the vascular structures, is very, very important. And the goal is to create a subepithelial seal mechanism with whatever agents we create. There are many ways to do injection. There are periurethral techniques. Again, the scope can be placed in the urethra. The injection can be made truly periurethral into the mid-urethra, or there is transurethral. And what we have learned is transurethral injection is probably easiest to do in the clinic for our patients. But we've learned that we should not inject only at the bladder neck, but we should inject at the mid-urethra, much as where we place our mid-urethral slings. And so the goal of bulking is to utilize the entire volume of the mid-urethra to the bladder neck to place the volume of bulking agent. Only at the bladder neck will fail. We need the entire, if you will, proximal urethra of the female urethra for purposes of creating adequate bulking effect. This is the usual appearance of the female urethra in the open position. And of course, in my generation, we were trained after bulking to create essentially the male prostate appearance of the female urethra, the complete bulking of the mucosa. So again, the difference between the before and the after of the injection. So again, the goal is to bulk, if you will, the lamina propria of the urethra to create or recapitulate the seal mechanism, the mechanism of closure for the urethra. So we now have two types of classes that we can inject. We have homogeneous gels, and we'll talk a bit about hydrogels in a moment. And then we have the historic particulate combination gels. And these gels are essentially created of microparticles in a carrier fluid. And these fluids essentially include a variety of solid agents, silicone, microspheres made of carbon, hydroxylapatite, or other agents that can be injected in the urethra with a fluid. So we're creating essentially the ability to inject a solid immersed in a fluid. And that's the difference between a hydrogel, which the entire volume is the gel itself, versus the microparticles, which we all have, as older people, we have learned as being the main agents which we inject. And again, these are agents that have a solid within a liquid. And the liquid is usually an alginate or a complex sugar molecule, a dextrose molecule, to allow the solid to be injected into the tissue easily for purposes of bulking. If we compare the agents, if we compare the particulate gels, which are the gels we have used for over many, many years, the bulking effect is due to inflammation. The body responds to the particles in the gel once the gel has been reabsorbed by the body. And the problem with this, there is significant volume differences. So many of you have used agents such as coaptite, macroplastique, and Durasphere, all of which are man-made or synthetic materials that allow the bulking to occur. The problem with this is the bulking agent is the material plus the fluid, and the fluid is reabsorbed by the body. So the volume that we eject is not the volume that the patient has long-term after the injection. With the bulking agents, the bulking hydrogel agents, it's only essentially a hydrogel, which is a very small percentage and essentially linked to water. And the water basically freely exchanges with the gel such that the volume remains constant. And what you see in this small area of the slide is the effect of the solid agents and the inflammation associated with that versus the hydrogel, which creates a uniform collagenous ingrowth response without fibrosis, which is a very important part of maintaining the volume of the injection. So not all bulking agents are created equally, and there are these differences, again, between the particulate materials and the homogeneous hydrogels, which we'll discuss at the end of the presentation. So Mauricio and I are old enough that we remember the use of bovine or cow-related collagen. And the problem with collagen is it had a rapid degradation, rapid loss of effect. And so the volume decreased dramatically. And this was also associated with loss of effect. So that by about 2 years, most of the effect of the collagen had been lost, and the patient had returned to somewhat under 50% recognition of response to the injection. And you can see the dryness associated with the various years. And remember, these are older data. And so dry in those days was different than how we define continence now, which is very much more rigorous. And Mauricio has been a great leader in defining outcomes. And I will say Mauricio has just submitted several very important journals to the Neurourology Journal, important articles rather, that really help us define the outcomes that are most important for patients. After collagen came hydroxylapatite, which essentially is a solid material. It's like sand. And the sand has been used for years in dental indications, orthopedic indications. It is biocompatible. It is not encapsulated. And it's relatively easy to inject. You can see it on an X-ray. And many of us who've injected this have seen reports from our radiology colleagues that suggest there is a stone in the urethra. Well, it's not the stone. It's actually the agent that's injected that has a calcium content that is relatively substantial that can be seen on radiograph, not only plain film, but also CT scan. It is relatively inexpensive. It does remain in the tissue. It is biocompatible, and it has no need for special injection capabilities, including refrigeration. It does cause minimal fibrosis. It isn't compatible. And there's an engineering term called rheology, which means flowing through tissue. It flows through tissue relatively well. This is what it looks like under the microscope. It's very uniform particles. As you can see, they all look like very small cells. And this is what hydroxylapatite appears and how it presents itself to the tissue. This is the wound healing characteristics. All these areas, these spaces, are the actual hydroxylapatite crystals. And this is the muscularis of the urethra and some fibrotic ingrowth that the material causes after injection. It remains stable over time. It is basically non-immunologic. It doesn't cause immunologic reaction, but it does cause fibrosis. And so that's a very important problem with this particular material. I have for years used this. I still use this now because of my institution. As I said, it is radiopaque. It does show up on X-ray, and so you can see it on both plain film and CT scan. And again, this is a plain film showing the injection of the coapatite, and note the date of this film. So it's been with us for almost 2 decades. So it's been around for clinical use for a very long period of time. The initial studies suggested it was somewhat similar to collagen in terms of improvement, and actually was superior in the initial studies when we looked at patient activity grade improvement after the injection of the material, collagen versus coapatite. And what we saw was that over time, coapatite patients usually did better in terms of responsiveness as compared to collagen. And actually with collagen, over time, there was a worsening, as you saw with my initial presentation. Treatment outcome was associated with reduction in pad weight. And again, pad weight leakage and percentage of patients with leakage is a very important way that we monitor responsiveness to bulking agents. Another agent that historically came after coapatite was carbon particle technology. It's again a particulate technology. You can see the particles, and they are suspended in a dextranomer or a sugar-based fluid that allows the material to be injected. It is not antigenic. It has undergone FDA trials. There was a trend to fewer injections with this particular mechanism, the carbon particles, as compared to the coaptide, but it's very difficult to inject because the particles obstruct the injection needle and makes it very difficult for us to inject. And therefore, this injection was basically changed to have a very large bore 14 French needle to inject. And of course, this is very difficult to do on outpatients, but you actually, with large needles, could place the carbon particles in the tissue with relatively good location. But again, the problem was the particles are only approximately 1/3 of the volume of the injection material. The other volume is the fluid that is absorbed by the body, never to come back. And so that's a problem with both this and the other types of materials that we'll talk about. And again, this simply summarizes the experience with the carbon particles. And as you can see, the experience was very wide in terms of success, 20% to 80%, depending on the length of follow-up and again, how cure and improved was defined. There were also studies done with carbon particle versus collagen. And again, you can see the differences in response rates depending upon how the studies were defined. And again, I want to credit Mauricio with many of his recent publications that actually look at how we should define continence and how we should look at improvement from the patient's standpoint, from how the woman perceives her urinary symptoms in terms of responsiveness. There was some initial results with this particular agent looking at up to 2.5 years, and there was responsiveness of up to 40% of patients were remained improved at 2.5 years after injection. Again, this was unusual, though, with this particular agent. The other problem with this agent was it created significant tissue effect. And so this is essentially the urethra, and this is a pseudo, if you will, prolapse with the carbon particles actually forcing the urethral mucosa through the urethral lumen. So again, the tissue healing qualities of this material were not very good. So prolapse and mass in the urethra were reported by multiple studies. And again, what was thought was the amount of volume injected was really critical. We did not have a standard volume that was injected. And so we had volumes as small as 2 cubic centimeters and volumes as much as 20 cubic centimeters being injected in a very small area. And that, as you can tell, would cause problems for urethral prolapse and other urethral complications. There were also uses of this agent reported as salvage for failures of mid-urethral sling. And as you can see, some patients actually derive benefit after mid-urethral slings. And as we know, bulking agents can salvage sling partial responders. And this is, again, something we should consider long-term for management of our patients. So it should be Durasfer and collagen. And again, as we can see, there is really no difference between the two. The cure rates are somewhat similar. Retention is more common when you combine the two agents, and this is in a circumstance where both Durasfer and collagen were used. And again, this is very ancient data now as compared to what I'll be presenting to you in a moment. We don't know what happens with carbon particles long term. They actually re-engineered the formulation, and what I think you have available in Latin America is what's called EXP, which has fewer carbon particles per unit volume, and therefore it's easier to inject, but it creates less volume. And so the effect of benefit for the patient may be impacted by the less volume of particles that are injected. Silicone has been with us now also for almost as long as carbon particles. It is also suspended in a gel formulation. And it has similar volumes implanted to what historically we used to implant with collagen. However, the particles do migrate. It's extremely hard to inject, and there's a risk of urinary retention that's higher actually than with some of the other injectable agents that we have. Because of the pressure that's required to inject it, it requires a gun or a pressure mechanism to inject it, and this approximately 2.5 cc's are injected per syringe of injectable material in multiple areas of the urethra. Notice the golden color of the material that is injected. This is what the material looks like. The material is very irregular in particle size and quality. And this is part of the problem because it has a very wide, if you will, amount of very small to very large particles, which again allows the possibility for embolization of these particles. It does cause significant fibrosis as well because of the tissue reaction to it. But still, it's being used by many people. And the implant results do show that there is some benefit. Again, dry is noted by the lower bars and improved as noted there. And as you can see, there is data to up to 36 months suggesting that there is some retention of benefit in approximately 50% of the patients who receive the silicone microimplants. There's also been longer-term data reported on this. And again, from 12 to 36 months has been reported with improvement in not only quality of life, but also urinary volume loss from a pad weight testing. And this simply shows the benefit of the agent. And again, compared to collagen and Bulkamid, and again, these agents do change with time, and this simply shows the difference between the overall benefit from, in this case, Bulkamid and collagen, but also macroplastique. And again, patients, in terms of their improvement, do vary in terms of their responsiveness to these agents. So let's look at Bulkamid. Bulkamid is essentially the hydrogel, which is different than the older agents. It is almost completely water cross-linked to a hydrogel. The water is freely exchanged with the host after injection, so the volume is retained. And this is a very important distinguishing factor between the Bulkamid and the other agents utilized. And this is some of the early U.S. data, and as you can see, I was the medical monitor for this trial. And the primary endpoint of urinary incontinence reduction was substantially improved in these agents as compared to Contagen, with approximately 50% of patients having zero incontinence episodes at the 1 year follow-up. At 2 years, similarly, results were noted that showed similar results. And again, the retention of benefit with the Bulkamid, with the hydrogel, showed that it was retained over time, up in this case to 24 months, which is very important. And then this is even longer term benefit at 5 years. And it's very interesting. You can see after injection, the retention of both not only benefit, but also improvement from the patient quality of standpoint in terms of improvement. And interestingly enough, if we were to do vaginal ultrasounds on these individuals, the volume injected would remain the same. And this is a very important difference between the hydrogels and the particulate injection agents. The hydrogels do retain their volume as compared to the particles. And finally, this is a 7-year data study looking at hydrogel. And again, notice the benefit, the sustained benefit in this case, in a single population group over 7 years. And it shows that, again, these patients do tend to maintain benefit with hydrogel as compared to some of the other agents that are utilized. The safety, I'm sorry, the color is not so good, but the overall adverse events are very low as compared to all the other agents. These are simply the data studies that have reported for the hydrogel. And again, as you can see, large numbers of patients. Retention is very low in these patients, and with follow-up time, as I said, up to 7 years. Now, there has been recent data from Finland looking at this agent versus mid-urethral tape, specifically TVT, done in a randomized controlled trial basis. And what this shows us, essentially, the Bulkamid is injected in 3 locations around the urethra as compared to a randomized trial against mid-urethral tape. And the timelines of follow-up were initial 1 year, and they've just reported the 3-year data, and the 5-year data will be forthcoming very soon. And this is what the bulking agent does. Essentially, it creates a bulking effect in the urethra to close or recreate the urethral cushion or mucosal seal. And what this study did initially was compare the Bulkamid, or the hydrogel, to TVT. You can see 113 patients to the Bulkamid, 111 to the midurethral tape. In this case, the first set of data, it was reported at 3 months and again at 1 year, comparing the two. And what they found at 1 year was the overall patient satisfaction, which was a primary endpoint, was very high with the sling, not surprisingly, but was also fairly high with the Bulkamid, 85% versus 99 at 1 year. And if you look at negative cost stress test, again, there was a better responsiveness with the midurethral tape, but the Bulkamid was actually fairly robust in terms of its responsiveness. And as you look at the patient-reported data, so again, this is an objective data, clinical trial data. This is the patient-reported data. And notice the cured improvement rate between the two. So very close data, interestingly enough, at that time, looking at the results. And then looking at the side effects, notice that the overall Bulkamid retention and risks of other issues were very low as compared to TVT, with really the only effect being post-injection or post-operative urgency, as we all know is a real risk with any incontinence operation. But none of the other risks that are associated with some of the surgical procedures are associated with Bulkamid. So the question is, does the risk-benefit profile benefit the patient? And it could be argued that, yes, the overall effect of Bulkamid is somewhat less than TVT, as Mauricio asked me to speak to, but the safety profile is certainly very robust and stable over time. So before we go into other bulking agents and other types of treatments for the urethra that are minimally invasive, the 3-year data for Bulkamid has just been reported. And again, the safety data is very similar to this slide, but there again is a difference between the midurethral tape and Bulkamid, which is approximately a 15 to 20% difference between the results of the sling and the results of the bulking agent in terms of overall cured improvement rates. So the question is, does the risk-benefit profile benefit patients to consider Bulkamid? And I'll leave it to you, but I would say with a very low risk profile in patients who have certainly other health problems, the consideration for a hydrogel bulking agent as compared to the other agents we discussed is a very reasonable consideration as we move forward in terms of next steps for our patients. Now, I did want to discuss some other new technologies that have come forward. Microballoons have been investigated for male post-prostatectomy incontinence. As you know, this is simply what the balloons look like. And again, this is simply after injection. There is some data, and I believe Paulo Palma has done this, and Mauricio, I believe, has done some of these microballoons as well. They do have benefit for certain unique patients. It's a bit of a more complicated procedure and does require X-ray guidance to ensure that the urethral balloons are placed at the bladder neck, but there is benefit of these for selected patients. And then finally, I'd like to discuss the use of autologous cells harvested from the individual. And I've been privileged to be a medical advisor and also a clinical study site for the use of self-derived myocytes, which are injected around the urethra under ultrasound or visual guidance, and following the results of these particular injections. And how this is done is cells are obtained from a muscular complex, and we usually harvest through a large bore needle under local anesthesia myocytes from the tensor fascia lata group. Those cells are then sent to a harvesting process facility. The cells are expanded or enlarged, and then the volume that is shipped back is often 10 times to 30 times what is obtained, and that is injected in the urethra for purposes of essentially re-establishing the muscular control mechanism of the urethra. Very exciting technology, but very expensive technology. And this is simply, the harvest procedure. This is what the myocytes look like initially when they're harvested from the skeletal muscle. And this is what they look like after they have been expanded. They actually form these myologic structures, if you will, myotubes and myofibers, And these are then injected into the urethra and recapitulate the sphincteric mechanism through not only a bulk effect, but also, we think, a mechanical effect that recapitulates the sphincteric function. And this simply summarizes some of our early data looking at the optimization of volume of cells. And what was clear, this simply shows that the more cells that are given, the more likely patients are to have greater improvement. And so now the number of cells given in the most recent study is 50 million or more cells given by injection for purposes of treatment. It is given by 2 injections, a first followed by a second injection if the patient's symptoms necessitate it. And again, the goal is to try to recapitulate or recreate the seal mechanism of the urethra. It is a very safe technique, as you can see. There is obviously, with everything we do in the urinary tract, a risk of infection. There was one patient in our early studies who had worsened incontinence, one patient who had biopsy site hematoma. And interesting enough, there were some allergic reactions related to the initial harvest materials that have been now changed. And there was one patient with retention that lasted for a very short period of time. But what this tells us is that using self materials is very safe for patients, and patients actually are very excited about the chance to use their own tissue. So, what is the current role of bulking? Well, the current role of bulking is that in the well-selected patient, we can use it both in stress incontinence and stress predominant mixed incontinence. In other words, with patients who have some degree of urgency. And for certain patients, we can use it as first line therapy, especially in patients who have multiple comorbidities such as heart and lung problems, patients who have minimal hypermobility, and individuals who wish not to have surgery. And we can offer this to these patients, especially with the hydrogels, with the knowledge that it's very safe and reasonably effective, especially as compared to surgery. Also, we can use bulking for salvage therapy, and we have data with multiple trials now, and this is some of our data looking at the use of bulking for salvage therapy, and we can actually substantially benefit patients who have, we can substantially benefit patients who've had a partial response or perhaps have not had a very good response to slings with the use of bulking agents in efforts to try to benefit them long term. So I will say and conclude tonight by saying that bulking is, in my mind, a viable option for stress incontinence. It may be used in not only salvage circumstances, but in cases where the individual is accepting of perhaps slightly less benefit, but essentially no risk for injection. And again, we have ongoing development with potentially nanotechnology and also cell biologic technology that will allow us to use autologous tissues better and also hopefully make the body better receive the injections that we give, so that the much as in cancer when we have the concept of metastasis going and we have seed and soil, the same for the injection of these materials. If we can improve the tissue around these materials, perhaps we can even benefit the patient more. So much study is going into cytokines and other tissue materials that may perhaps we can benefit the patient by increasing them to increase and improve the overall healing technology. Mauricio, thank you very much. I very much appreciate the chance to speak to you tonight, and it's a great honor.